think it's on. So, yeah, you got to do your job. Get out of my pocket here. Think it's on? Okay, great. Okay, hello everybody. Good afternoon. I'm just going to briefly talk about causes and preparations for audits while you enjoy your lunch today. My name is Jessica Sheldon, and I'm the Equip Administrator and the Human Research Protections Office in the Office of Research. Equip stands for Education Quality Improvement Program, and we do things like come out and do presentations like this and do routine monitoring. So after you've gone through the IRB, so I'll start off after you've gone through the IRB process and gotten IRB approval. Okay, so congratulations, your study's been approved. What do you do next? You want to start keeping accurate and complete protocol records. And we like to emphasize that this is the responsibility of the lead researcher. Although you have key research coordinators and other study team members who are helping assist with your record keeping and documentation, ultimately it is the responsibility of the lead researcher to keep this documentation. A lot of researchers also say, well, you have your records, you have your red files, I mean, you keep records. We do keep records, but that's an obligation for us to meet the university's record-keeping requirements. It's not necessarily to keep the documentation for you as the researcher, okay? So when you receive IRB approval, you'll be sent a letter, an email that says, congratulations, you've been approved. Please go to this website and download your documents. So you want to go to that website immediately when you receive that email and download your IRB approval letter, your approved protocol narrative, your approved consent forms, your recruitment materials, and your data abstraction sheet from this website. Keeping in mind that there could have been multiple revisions that occurred from your initial to submission by the time it was actually approved by the IRB. So you always want to use and keep these files on record. We do provide editable as well as the PDF stamped versions. A lot of people like to try to use their prior versions, which may not reflect all the revisions that were finally agreed upon and approved. Okay. And you might have multiple IRB transactions. You will all have your initial IRB application and approval, but you might have subsequent modifications, changes to your protocol. You might have subsequent renewals. And so you want to keep your IRB approved documentation for every transaction that you have for accurate record keeping purposes. And finally, you want to make sure for at least for the initial and your renewal applications, they require signatures from yourself, if any of you need faculty sponsors, and your department chair or director. You want to keep those on file as well, a copy of them, because they sign an assurance and it's kind of like your contract with the IRB. So you want to keep a record of what you've signed on file as well. After you've maintained your study documentation and you're ready to close your study, this is the criteria when you're ready to do so. When all your recruitment and enrollment is complete, when all your specimen records and data have been obtained, when there's no longer any contact necessary with subjects, when your analysis of subject identifiable data and or specimens is complete. That means you can continue to analyze completely anonymous data without access to a key code without IRB approval. And the review of your source documents is complete, especially if your sponsor supported research and the sponsor wants to look at your source documents, that needs to be completely done as well. So when you're ready to close your study, you can submit an official closing report with the IRB. Okay? And the reason why we bring up closing your study is everybody wants to know how long do I need to retain my records for. Per the regulations, you want to maintain at least your records for at least 3 years. We have additional lengthier requirements for data retention, and we'll go over that in a minute. But you want to at least hold your research records, which include your IRB documentation, your approval documents, your case report forms, all of this is de-identified, by the way, and anything else related to your data collections for a minimum of 3 years. Okay. If your research involves Medical record access, or data that was generated from medical records, which is PHI, you want to keep it for a minimum of 6 years. If your research involves minors, children, you want to keep it for 7 years after they turn the age of 18. This could mean if you're enrolling 1-year-olds that you keep it for 25 years, right? And we just like to make a note, it's when 7 years after all the minors in the study have reached the age of 18. So it could even be longer than that depending on how long it took you to enroll the children in your study. Yes?
You said de-identified. Isn't the point to be able to, if something happens, know which subject was which happened to, or?
It depends. That's when you close your study. But otherwise, you want to maintain an active IRB approval if you need identifiers to figure out who is who for that period of time. So it could be the case that you keep, maybe your study is done in 3 years, but you need to keep it for additional 6 years to verify the medical record access and things like that.
Interesting. So for 6 years, we're supposed to keep the data key, but we can't close the study if we keep the data key.
So that does sound a bit confusing, but you can close your study as soon as you're done with the data key. And then you want to retain the de-identified data relevant to that research for 6 years.
So we're supposed to get rid of the data key?
Yes. Yes.
So then what's the point of keeping it for 6 more years if we don't know who's who?
It's just HIPAA regulations require that you maintain a record of when you access medical record information. You might not have direct identifiers to whose medical record and what identifiable information was maintained. It's just that it was accessed and for what research purpose.
I guess that's confusing because I'm assuming the reason you're supposed to hold on to the records for minors for 25 years is because you want to know if there's some sort of late side effect that they're developing. And we're going to have no way of knowing.
It could be that, or you want to just validate your results, or somebody wants to look at your source documentation. But doing that doesn't necessarily mean you have to have identifiers, names, addresses, contact information, things like that. Okay. And similarly with children, if your study involves in vitro fertilization or pregnant women, the fetus, you want to keep those records for 25 years. Again, de-identified records. Or if you need to keep identifiable records, you maintain an active IRB approval for that long. Yes?
If it's a mixed study where you have minors and people and subjects over 18, do you need to keep all the records?
Yes.
Until the last?
For the longest period of time. Correct.
Okay.
If you are well organized enough and you have it categorized and you can do that, then you could keep it for one cohort for the 6 years, the other cohort for the 25 years. And that might be important for your storage and filing purposes. Okay? If you're an FDA-regulated study, because your study involves investigating a clinical drug or device, you might need to keep it longer than the stated period for the general regulations. So if you're doing a clinical investigation of drugs, you want to keep it for 2 years after your marketing application is approved. Or in the event that your marketing application is not approved, you want to keep it for 2 years after the investigation is continued and the FDA is notified. In addition, if your sponsor supported research, you also might have contractual obligations with your sponsor to keep it for longer periods of time. Okay, and you want to check in with your sponsor for that. Okay. So when it comes to audits and inspections, we're looking at your documentation. That way we can verify whether it was conducted in accordance with the regulations for protecting human subjects and institutional policies. And pretty much all we have to verify things are your records. So if your documentations aren't adequate, then it kind of didn't happen, or if it's not there. Right? If the documentation to support your research is not available, it can open yourself or the researchers to fraud allegations. And fraud allegations are just allegations, and they are followed up on, and any allegations of scientific misconducts are rare. but we do follow up on those and inspect those because it affects the public's confidence in the clinical trial process, and it raises questions about the effectiveness of your trial. So here at UCI, our Office of Research, the larger department I'm in, that we handle issues of scientific misconduct. If it turns out to be that we're leaning after our inspection that it appears to be a case of allegation of fraud or scientific misconduct, we refer you to the National Office of Research Integrity. And we have a reference here, and they have some interesting examples of scientific misconduct, fraud that has occurred in research that you might be interested in taking a look at. So we just like to reiterate what the goals are for audits and inspections. We want to assure the human research subjects protections are in place. We want to assure that the data is accurate and reliable. We want to assess compliance of your protocol. We want to detect any fraud or misconduct, as mentioned. We want to talk about process improvement. That could be for department staff, maybe more education. We want to assure quality control of the documentation, and we want to always be ready to prepare for an external inspection. When we come out, we're going to ask ourselves, are any actions needed for the organization to come into compliance? That would either be your department or the IRB itself. Is there something we could have done better to help you prepare for an audit? And we always consider whether there are any regulatory sanctions required. Here at UCI, our auditing program is managed by the Office of Research, our Division of Education and Quality Improvement Program, where we conduct routine monitoring visits. In addition, there's the Office of Research Oversight at the UCI Medical Center, and they do their own routine audits of clinical investigations. And together we do research, we do reviews, and we provide reports to each other to keep each other in the loop of any of our findings. Regarding the QUIP, UCI likes to do at least one review per month, so that's about 12 annually. And we divide it up into try to do half social behavioral, main campus studies, and half biomedical studies. We conduct these to ensure, again, that we're conducting research in accordance with regulations, laws, and more importantly, institutional policies, how UCI says we're going to be doing the research. This process of auditing is part of our requirement for our federal-wide assurance to receive federal monies, and it's also an expectation of our accrediting body, the AHRP, which is the Association for the Accreditation of Human Research Protections Programs. So the types of research that we come out and routinely do, we try to evenly distribute it and visit each department once throughout the year, if we can. So I think we came out and visited one of our investigators at Beckman this year, so you won't see us again for a while. And we focus on biomedical and social behavioral research that is generally greater than minimal risk to subjects, or research that includes special or vulnerable populations, research that's investigator-initiated and or sponsored, research that involves sensitive personal information, and we also review expedited and exempt research, minimal risk research. Okay? Sometimes, unfortunately, we do have to come out other than routine audits, and we also come out for cause. This is when we respond to requests or we notice unanticipated problems are occurring in the department, or sometimes a subject has called our office and complained about the ongoings of the research and the participation in the study. And once those complaints are verified and founded, we might come out for cause just to make sure everything is being conducted in accordance with the regulations and policies. Okay. When we do our internal audit, well, I say internal, that means UCI, this process will take place over the course of one day and may involve several hours. We do our own quality improvement assurance review of our records before we come out. And when we come out, we'll do an initial meeting with the lead researcher and study staff. These could probably be like your research coordinator or your key personnel who are mostly involved with your data record keeping. It takes about 30 minutes for this first session. And we just ask a few questions about the purpose of the study and what the procedures and processes were involved. After that, we're going to actually audit and review your records, your subject files, your case report forms, any records that you have kept related to the research. We ask that one of the members of the study team be available for the duration of that record review, just in case we have any questions or we can't find anything. And those individuals don't have to be in the room. They can just be available to us by phone call. Your records can be kept in electronic or hard copy format, whatever your IRB approved protocol had indicated. Okay. As part of the exit portion, which will take 30 minutes after the audit review process, we present any preliminary findings we might have seen to the lead researcher and the study team. And then at the end, 10 business days after the review, we'll issue a formal report citing any findings we found and may require a response. Sometimes these findings we see are just recommendations for good best record keeping practice that don't really beg a response. Either way, the results of any monitoring visit we do are reported in writing to the department chair or director, the directors of the Research Protections Office, and the IRB full committee, so that they can review what's been going on in the research. We encourage you, so you'll get a notification of an equip audit. And when you do, we'd like to set up a time, and we offer these tools that are available to help you prepare for an audit, and they're free to download. The first is a signature log for study staff. When you obtain when you're required to obtain sign-informed consent, we highly recommend you have a signature log. There's a signature line and also a printed name line. So we should be able to figure out by the printed name who signed, but sometimes people's printed names are just as illegible as their signed names. And so a signature log helps to identify, number one, that person was authorized to obtain informed consent, and then who that signature belongs to. We also have available a study visit log, and recommend if you don't have your own template for a study visit log, you download our version. It's basically a cover page for each study visit you have with the patient, and that can be placed in the subject's record. It records the time, date, duration, who is involved, and any notes relevant to that subject visit. The tool that's titled Equip Expectations for Biomedical Researchers, that's a list of all the common study documents that should be retained in your research records. It's not an all-inclusive list, but it has the majority of the list, the documents that you need to maintain. So in preparation for our visit, we ask that you review this checklist and make sure you have all the study documentation and you know where they're located, either electronically or in a hard copy fashion. That's the EQUIP internal UCI auditing program. We know, although I don't think there are very many researchers here at the Beckman Laser Institute that are subject to FDA regulations, but a few of you might be. You might be investigator sponsors, or you might be required to have an IDE or something like that for your drug or device. In that case, you'd be subject to FDA inspections, and the FDA can inspect clinical researchers, IRBs, sponsors, the CRO that your sponsor has contracted with, or other agencies. Other agencies are those entities that are involved in submitting clinical data as part of a new drug application. Okay. When the FDA comes out, they're looking at good clinical practice to ensure that sponsors are conducting the research in accordance with good clinical practice. So they're going to look at the standard design, conduct, performance, monitoring, auditing, recording, analysis, reporting of clinical trials to provide assurance that the data and reported results are credible and accurate, and that the rights and safety and well-being of the trial subjects are protected. Okay. When they come out, they're going to ask, were sufficient monitoring resources allocated to the project for on-site monitors and medical monitors? Were corrective actions taken when deviations, violations, errors occurred? Did the monitor assess drug storage and accountability routinely? This is particularly important if you are the investigator sponsor who is the holder of the IND. They're also going to ask, how was quality data assured? Data quality assured. Were the statisticians who reviewed the data, were they qualified based upon their training and expertise? Was the statistical analysis plan followed? The types of investigator inspections that occur are going to be routine inspections, or they're going to be triggered by a new drug application. New drug applications, every drug is subject to a new drug application before it gets in the U.S. before it's commercialized. It's the vehicle through which drug sponsors formally propose that the FDA approve a new pharmaceutical for sale and marketing in the U.S. Okay. I don't know if Beckman laser generates new drugs, but if you did, that would basically trigger an FDA inspection. Other times, there's directed inspections for cause or for other triggers. For cause, as you can imagine, are triggered by allegations that raise concerns concerning data integrity, rights, welfare, and rights and welfare of the subjects that have been compromised. Other triggers could be pivotal studies, high enrollment, irregularities in drug management, and high percentage of subjects excluded from the population. When an FDA auditor comes out, what's going to happen is they're going to notify the investigator about their arrival. They're going to show up, show their credentials, and give you prior warning of their arrival. The FDA is authorized at any time to have reasonable access, inspect, and copy records, and any required records related to clinical investigations. They're going to primarily meet with the investigator and ask a few questions. Then they're going to meet and interview your key personnel. They're going to look at your study records, and they're going to conduct an exit interview. When they come out, they're going to inspect your records and talk to individuals involved in the conduct of the study. They're going to try to ascertain who performed various aspects of the protocol for the study, including who verified inclusion-exclusion criteria, who obtained informed consent, who reported adverse event data. They're going to look at whether the IRB approved protocol and informed consent and the amendments were approved, and if any changes were made prior to the prior to IRB approval. They just want to make sure you're not making changes without notifying the IRB. They're going to look at the clinical investigator and study staff to make sure that you adhere to the protocol, and when, again, protocol deviations occurred, what was the corrective action plans or actions taken. They're going to verify your informed consent documents and make sure they were signed by the subjects or legally authorized representatives prior to entry in the study. They're also going to run into specific aspects of where the investigation were performed. They might want to look at your lab. They might want to look at your clinic. They might want to see where subjects' procedures were performed. Okay? And at the end, they're going to they're going to have an exit interview with the clinician and anyone else of key interest. If there are any findings, they'll issue a 483, and that's the inspectional observations. They'll cite anything that they thought, basically any deficiencies that were found. and basically, any observations in the opinion of the FDA represent deviations from the applicable statutes or regulations. Some of the common findings the FDA may find is failure to follow the investigational plan, protocol deviations again, inadequate record keeping, inadequate accountability for the investigational product, which would be the drug or device, inadequate subject protections during the informed consent process. If you do get issued a Form 483, you can respond in person at the time of the exit interview. You can respond in writing formally to the FDA, which is always recommended. Once you've responded, the FDA will actually review the findings, your response, and then issue a final letter. And the letter is going to either say no action is needed, basically saying that they observed that your research was in basic compliance with the pertinent regulations. They're going to say maybe voluntary action is needed. It might identify a few deviations from the statutes, but don't really meet the regulatory threshold of significance of a warning letter. Or they're going to issue a warning letter that says official action is needed. They're going to identify serious deviations from the applicable statutes and regulations and ask for corrective actions. And we just like to remind you that FDAs don't just audit study teams. They come and audit the IRB. For the same reasons, they might come out for cause or they might do routine audits. But when they come out and audit the IRB, they interview the IRB staff. They ask us about policies and procedures. They look at one or more studies that are under their jurisdiction. They're going to look at our IRB membership, our procedures, our minutes of the meetings, the materials that are submitted to the IRB and the documents we develop. They're going to report whether the IRB has been non-compliant, if there's any areas of quality improvement, whether we can do better for the organization, educating our staff, educating our researchers. The FDA has the authority to withhold approval, to cease enrollment of subjects, and to terminate ongoing research if they find that the IRB was inadequate. Okay. They could, in serious circumstances, also notify state and federal authorities and disqualify our IRB. We left a lot more time for questions, as I think Montana said we would have questions. But the key points are documentation is key. It's proof of your research was conducted ethically and collected appropriately. And we always have other our resources are available on our human subjects website for further review. So that was a bit quick. I went through quickly, but does anybody have any specific questions regarding either the UCI's process for coming out and doing a routine audit or the FDA auditing, or just general questions about conducting research at UCI? No? Okay. Oh, sorry, yes. Yes. No problem.
Question about records, medical records.
Yes.
And I know it seems like there's been kind of a shift over time towards data extraction sheets. And
Yes.
So, so I guess the blunt question is, are we allowed to keep a copy of a medical record if we de-identify it? Or do we have to transcribe it into something else?
That's an interesting question because we just met with the medical records group yesterday. So keeping a copy of it would be considered like a shadow copy, right? And you are not allowed to keep that. You're allowed to extract variables from them and keep them in your research records according to your approved data abstraction sheet. And your data extraction sheet is your approved variables from the IRB that you can extract from medical records. And the IRB's role is to make sure you only need the minimum variables necessary to conduct the research. So in regards to copying the medical record, it seems that that would have more information than you need. And even though you're redacting it, you really should probably set up a process to only extract the information you need and are approved to extract and keep it in a separate hard copy file, electronic spreadsheet, however is easiest for you to maintain that record keeping.
So you guys agree with medical records people, meaning if we were approved to have that information, we would have to literally hand copy all of it. We couldn't just make a photocopy and redact the identifiers.
And my understanding is most medical records are going electronic. Do you find that you come across a lot of paper records, paper medical records?
Well, it's for both. When we keep a local copy, it could be an electronic PDF of an electronic of an EMR, or it could be, a locked in a binder in a cabinet somewhere. So to me, it's the same thing.
Currently, we don't have electronic medical records.
Okay. So then you're in the paper version, which now your question makes more sense to me. Because with the electronic medical records, you would go to the stewards, ask them for certain variables, and they'll make those available to you, right? They'll shoot you a little spreadsheet with the data variables you requested at the medical center. When you have paper records, you're kind of on your own to do your data mining and collection of information. So am I in agreement with them? We tend to support each other. The Office of Research Oversight, so we support each other. I do see the logistics, the problem in the logistics of doing so. The problem with redaction is it's subject to human error. Sometimes you're in a rush and you didn't redact. And when we come out, we see that it's not redacted and there's more variables in your records than you were authorized to collect. That's the problem with copying and redacting. In addition, sometimes redaction is insufficient. Are you crossing it out with a pen? What is your method of redaction? Could we still see the information in the hard copy format to figure out who that individual was? Whiteout is not good clinical practice, so we don't want you using whiteout on there because whiteout can be scratched off and you can see underneath the whiteout. So there's some problems with redaction in that it increases the probability of human error such that inadvertently you might have identifiable or more variables in your research records than you were authorized to do, to collect.
So I agree with that. So there's two logistical problems. One is in pilot studies in particular, we don't know all the variables until we do the study. Right? So that's one kind of basic issue with that. The second is, so all the electronic medical records I've seen have just been paper records put in an electronic system.
Scanned in kind of
No,
thing.
not even scanned. It could be a Word document of an imaging report or a laboratory, but it's in a paper format, just inside the computer.
But that's not actually true of most medical records, so there are
That's
those.
what Quest is, right?
No, it's not. It's not. We input material directly into Quest, so it's, and there,
But when we material out, we're just looking at pages of narrative and text.
yeah, they break
You don't
down.
actually search and say, show me all the people with tumors greater than 2 centimeters. You need to find out.
No, you could.
Yeah, my understanding is the capability is there and they're making headways to make it more easily accessible like
You
that.
want to be there.
Maybe they want to be there.
And especially when you go to ICD-10, which they can threaten, but it's not happened, I mean, there things are going to be much more specific, and you should be able, all the codes will be very specific for location and size and kind of tumor and things like that, so the searchability of that kind of diagnosis and things should be much greater.
They're transitioning to Epic too.
Yeah.
It was a very unfortunate issue with Quest. There was money, but now they're going to go to Epic like most other people.
So, I mean,
So,
there's probably other researchers, and we work with MD Anderson and all these other places. They might have
Okay.
systems, but the data's just not entered properly. You actually need to see the original report to get an idea of what the data really is.
and when you're working with collaborators, is it the researchers that are sending you that information? Is it the patient giving you that information, or is it like their medical records people sending you that information?
If it's the researcher that's at another site, if it's here, it could be any of those.
Okay. Because generally, when researchers send information to each other, they're probably not doing it according to their medical record policies. in that, they didn't take the time to figure out how it should be appropriately sent, and then you might end up with a shadow copy of a chart, which is probably not in line with what they were supposed to do. Right.
Kaiser, for example, we send a records request to Kaiser, and they send us the records back. I mean, we're following their policy. The question is, once it gets here, what do we do with it?
So in that case, if they're following their policy and they give you complete access to their records, then it would be your responsibility to redact. As far as UCI-generated medical records, it's preferred until which time we can be electronic and EPIC and all that, that you create a separate, you basically record the data and not redact the data. Keep a separate file and record the information you need, as opposed to keeping a copy of the chart and then redacting it.
How do you recommend redacting? If we black it out and still see it?
So, and that's the problem with redacting. What are you redacting? Is it usually we say black marker, crossing out. You can still see it, and that's why we don't really like you to have a copy of it.
It shouldn't be redacted.
Yeah, you shouldn't.
Because we shouldn't have that paper.
Right.
We shouldn't have that.
The only things you should be redacting is you might have been approved by the IRB to collect name and medical record for a temporary period of time, right, to identify your individuals. But anything else, you shouldn't be redacting because you shouldn't even have access to it. I mean, you have access for your clinical purposes, but not for research purposes.
So is there an SOP or is it recommended?
My understanding, and again, I have to defer all these medical record questions to Andy's group at the Health Information Management of the Medical Center, but they say they have SOPs on this on the internet. I don't know, because unfortunately the IRB office doesn't even have access to the intranet. So the health services intranet. We're working on it. We've been working on it for a few years, but for some reason we can't get granted access. So we hear about this a lot, and it's something that we're just unfamiliar with because it's outside of our purview.
Thank you for coming here to give us a nice presentation. I'm not clear about the FDA regulated study. Is it opposite to the investigator-initiated clinical trial?
So sometimes when you're investigator initiated, if you are the holder of an IND or a device that is subject to the FDA regulations, then you will be considered a sponsor and subject to those auditing and monitoring as well. Most of the time, though, if you're not the investigator sponsor they call it, then that's just subject, your sponsor is subject to that monitoring. You have anything to add, Laverne? Yeah. So I know there's very few investigators, but there are a couple, I think, in this department where they might be using a drug off-label or for a new indication, which requires a IND and oversight from the FDA, or they created a new device or a laser that is considered significant risk that is subject to FDA regulations. And because they're the inventors or they're the ones that thought of that idea, they're the investigator sponsor, right? And I know Beckman Laser generally develops the devices. Very rarely, though, are they considered significant risk clinical investigations at this point. I think the majority of your studies tend to be feasibility studies that are physiology studies that are really studying the feasibility of the device at this time. If at which point it now becomes a medical device that you try to implement during patient diagnosis, care, or treatment, then you might be subject to FDA regulations depending on whether or not the laser is considered significant risk device. That would require an IDE from the FDA.
I see. So if the device or the drug targeting treatment, then you're subject to FDA regulation. If it's like fundamental imaging purpose.
Then not at this point.
Okay, I see.
But our understanding is that most imaging, you hope to eventually segue into medical or clinical indication, but until which time it doesn't go beyond that threshold, you're not subject to FDA at that point.
Not necessarily you have a sponsor or you don't have a sponsor.
Right,
Okay, that's clear.
yeah, yes.
Since you brought it up, can you talk about the middle path, which is you're doing an investigation on a medical device, but it is non-significant risk and the IRB has the authority to determine that. How does that procedure work here at UCI?
Sure, the procedure here at UCI, and as you said, the IRB has the authority to make a determination. Sometimes, let's just assume you're the inventor of the device. Sometimes maybe a sponsor is, and they've already reached out to the FDA, and the FDA has made that determination. But in this case, for this department, this institute, you're usually the inventors of the device. If it is a medical device, and you are using it and that purposes, it would have to just go to full committee, and the full committee would deliberate as to whether it was considered a significant risk device or not, or whether it met the definition of a non-significant risk device. If they decide it's a non-significant risk device, then it gets, it's part of that, and they're subject to abbreviated regulations in the FDA, but not the full gamut of the FDA regulations for devices. And then the committee will also decide whether or not that study remains at the full committee, which means greater than minimal risk, or whether or not it can be bumped down to a minimal risk study for subsequent renewals and modifications and things like that. But it always requires initial full committee review. So even though, in your opinion, it might be minimal risk to subjects, it has to go to full committee just to make the determination of the device.
I bet you know my follow-up question is, what if that device is used in a new study, the same exact device?
We make,
Have to get full reviewed again?
correct. We have to make that assessment on a protocol-by-protocol basis. For a new study, generally your purposes or aims or your focus are different, so we make that assessment on a case-by-case basis. You can't cite, in this prior study, this device was already considered a non-significant risk device, therefore I don't need to go to the convened IRB. Well, it depends on the details of the study and what's being done, so it's a case, it's every time it comes in, it needs to be revisited by the full committee.
It seems like there could be an opportunity to streamline. I don't know what the government should say about that, but we have that a lot because we'll make one thing and we'll do 6 different studies with it. And if it's, the same exact thing that's outputting the same exact energy in the same exact way in each case, it seems not a good use of human capital to have to review that same thing 6 times.
Sure, and I don't know, does the FDA, do they review it on a case-by-case basis too? Like if you consulted with the FDA and they came up with an NSR?
If you consulted with the FDA, it depends on the population that you're using it and method of using the device and several other variables. You have to get an FDA review depending on how you're using what population and other kinds of variables.
For the FDA part.
Yes.
And we would follow suit too. So following the same reasons, we want to assess per individual study because it's going to have a different aim, maybe different population, different use, different
I
indication.
think what you're saying is if you just, even if it's NSR, non-significant risk, you can still do an FDA review, and if they give their blessing on it, then that kind of applies for any study here, because that trumps the IRB's determination of it.
Yes.
Does that make sense?
Yes. So that's why I was asked about the FDA, because if you went to them,
That could be one way.
right, and then say, I have an
That's fire control.
yes, yes. But again, I don't know if they look at it on a protocol by protocol.
For example, there was a study where they used some kind of machine that helps with depression, and then now they want to use it for PTSD. I have to go back to the FDA because now it's a new indication, a different population, and probably a different level of energy being used on these subjects.
I should introduce my colleague here. This is Laverne Estinal. She is our new assistant director. So she'll be doing more education and quality improvement, outreach to this. She's very qualified and comes to us from the VA. She was previously here with the IRB with Team D Biomedical Exempt Expedited for 2 years, and she's graciously come back to us. So I should have done an intro before I pointed to her and started asking her to field questions. These are all excellent questions. So,
I appreciate that. That was a little murky.
I'm just curious, are you thinking about changing any of your devices to be considered more in the clinical indications?
We almost always have that decision to make when we go
Right.
through the study.
At what point?
As you said, as time evolves, it tends to push towards that side. So
Right.
We have to make that flip.
Right, right. Great. Any other questions? Comments? Great. Well, thank you very much. Thank you. A lot of information. You know, we can't go over everything. Everybody would be bored, but, you know, the point is come out, meet us, know who to contact.
I'm Jan Fisher. You guys, I know I've seen you many times before, so I'm glad you said you